Welcome back to Talking Shift, and today I have the privilege of talking with Dr. Anand Swaminathan from MRAP. He's a good friend of mine and a fellow resuscitationist, and today he's going to be speaking to us about something he's spoken about at the RESUS conferences, and that is this concept of the cognitive pause. This pause that you take during your resuscitation to ensure that you're on the right track, to make sure you're treating the right things, and you don't anchor in your diagnosis. We're going to get into this really deeply, but this is a very mature concept, but something that all resuscitationists should keep in mind as they're managing those patients. So without further ado, let's take you right into the episode. Thank you for being here on Talking Shift.
Oh yeah, I'm really honored to be here. Can't wait to get into the topic. This is going to be fun.
I really appreciate it. And this is a talk that you've given at ResusX before, and it's one of our most viewed videos. So I figured this is just an opportunity for me to pick your brain a little bit further and talk about it. And what we're talking about is the cognitive pause. Can you just briefly describe what that is?
Yeah, I think, in emergency medicine, critical care, resuscitation, we are so hyper-focused on the patient in front of us, getting that patient better. We often make a quick diagnosis based on a very small amount of information and then start moving forward with treatment, because if we don't, the patient is going to be in a bad way. So we start doing a bunch of different things. But sometimes the things that we do, the things that seem to fit with the diagnosis we have, don't work. And it's easy for us to have this cognitive bias and say, well, it just hasn't worked yet, or I just need to try harder and push harder on the thing that I'm doing, and to not take that step back and say, well, what else could I be missing? So the cognitive pause is kind of switching from the system 1 to the system 2 thinking. System 1 is that fast, really kind of shooting from the hip, making decisions based on tiny bits of information. But sometimes when things don't go the way we want them to, we really need to take a step back, switch to system 2 and say, what else could I be missing here that is either in addition to what I am treating, or I'm treating the wrong thing completely. So the cognitive pause gives us a chance to let our brains catch up with what we're doing.
I think it's such a beautiful concept because, and we've talked about this before, this cognitive pause, but what I think happens is that it takes a lot of energy, even mental energy, to switch gears and say, okay, we're going down this road, and you're like, what? It's not working? Yeah. Let's just keep going a little bit further, because it takes so much energy to switch gears, and you're already using a lot of cognitive energy in that moment. So I don't want to call people lazy. I just think it's inherent to the fact of, like, we're on this pathway. It's so much work to switch. Let's just go a little bit further and see. Right. The problem is, as you're going to talk about, is that that little bit becomes a little bit longer, a little bit longer, and a little bit longer. And before long, you're way deep in the resuscitation. Yeah. So why don't you take us into a classic case where this might happen, and then we could talk system points.
Yeah. So let's say you have a patient who comes in and they're complaining of cough, maybe a little bit of a hypoxemia, and the patient's got a blood pressure of 80/40. They're afebrile, at least by the mouth temperature, for whatever accuracy that has. They're a little cardiac. They're a little hypoxemic. And when you see that patient and you see tachycardia, hypotension, cough, it's really easy to go down the sepsis pathway. I think we're all going to do that, especially with all of the metrics around sepsis management, how fast you have to do things. So we see these patients almost every shift. I saw this patient my last shift, and what do? We popped in some lines, sent off a bunch of blood work, gave a fluid bolus, started antibiotics. And when the patient didn't respond to that fluid bolus, we started norepinephrine, right? This is all very routine resuscitative care, whether it is upstairs in the ICU, downstairs in the ED. So we started the norepinephrine, and I kind of went back to the computer to put in some orders, maybe check and see if any labs had come back. And maybe 5, 6, 7 minutes later, the nurse comes up to me and says, so I'm on max dose of norepinephrine. And we can talk about what max dose of norepinephrine is, but I'm on max dose norepinephrine. Do you want to add a second pressor? Haney, you ever been in this situation where someone tells you, I'm as high as I can go, what, you want to add a second one now?
Yeah, that's happened once or twice in my career.
Usually for you, it's, do you want to add a fourth presser? So, right. What do? I think it's really easy to say, okay, so whatever your quote unquote max dose is, I'm on 0.3 of norepinephrine. And I wouldn't call it a max dose, but it is a dose where you really have to think, oh, well, maybe the norepinephrine just isn't enough. And it's really easy then to say, okay, go ahead and add vasopressin. Or, okay, well, maybe the patient's cardiac contractility isn't good. Let's add a little bit of epinephrine. Or maybe they're just really vasodilated. Let me add some phenylephrine. It's really easy to do that. Or let's just give him another fluid bolus, right? We've all done that before too. So give him another 500 cc's and maybe it'll be sign out time and I can go home and I don't have to think about this anymore. So when that happens, what it should be is kind of that reminder of, am I dealing with the right thing? Have I missed something?
Yeah. And so, we can talk a little bit about what MAX really is, but, what's your cognitive trap? You refer to this in the lecture that we've heard before. Like, what is this trap that you talk about? Can you just put into words so people at home can be on the same page?
The cognitive trap is starting that second pressor, because we all have seen sepsis and septic shock patients who need 2 or 3 vasopressors. That's not that common though, right? That's not in every shift. Like you see sepsis every shift. You don't see septic shock refractory to norepinephrine every shift. I mean, not in the ED the vast majority of the time, right? That's not a common occurrence, but it does happen. And so it's a cognitive trap to just say, okay, patient's septic, they're not getting better, just add a second pressor, or just give them a fluid bolus and then we'll add a second pressor. It's kind of set up for you to just keep going down that way. And really what you need to do instead is slow down, take a step back and say, okay, so what I wanted to do isn't working. Why isn't it working? What could I be missing? What do I have to add to my treatment, or what do I have to add to my differential?
And at what point does that happen for you in the resuscitation? At what point are you just like, and you've seen many of these cases, but you must have had some sort of framework or architecture where it's like, when I get to this, for every patient I see, I'm going to start doing that. Do you have that?
I don't know that I have a hard stop point. I mean, definitely if someone's asking me to start a second vasopressor, that is a hard stop point. I've kind of lowered that threshold serially from, okay, 0.3 mics per kilo of my norepinephrine all the way down to maybe 0.15, so about half of that. So when I'm at like 10 to 15 mics of norepinephrine, I can still do another fluid bolus. I can still go up my norepinephrine. I can still add the second vasopressor. But that's my time to sort of take that step back and think about what else I could be missing. So let me just be clear here, Haney. It's fine to add a second pressor at this point. It's not fine to add the second pressor and not think, could I have been missing something? So that's usually the point. I mean, listen, if this person came in with cough and then they do a rectal temp and the rectal temp is normal, then I take a step back and say, okay, well, could this patient still have a pneumonia but not have a fever? Or if I get a chest x-ray and the chest x-ray is pristinely clear and the lungs sound crystal clear, and since you're an ultrasound guy, I ultrasound the patient and the ultrasound is crystal clear, then I'm thinking, well, maybe that cough isn't pneumonia. Maybe there's something else going on that's causing the patient to cough. So when there's some input, some data point that doesn't match with what I'm expecting, that's my step back. That's my reminder to take that step back. So whether that be they're not responding to my vasopressors, they're not responding to fluids, the x-ray doesn't look right, the rectal temp isn't right, something along those lines makes me think, okay, I got to reassess the situation.
I like that because, sometimes people want to know, they ask me, what's that number of vasopressor? And I think you pretty much nailed it. It's a constellation. I always think about a clinical puzzle piece. And so initially you only have a couple pieces and you put the piece together, that kind of looks like a boat or, and then you get some more pieces and it adds in, but there has to be, it takes discipline for someone to take a step back and say, you know what, let's put those pieces back together again. And then the puzzle can look like something completely different. And so you have to have that flexibility to say like, no, we're not going down this pathway because things are not adding up. And like you started this off, sometimes you have to get into the resuscitation. You don't have those pieces available to you. The lactate from the lab, the pH from the VBG, but that stuff will come. And when it comes, you have to be able to take a step back and be flexible. Where that point is, everyone is different, but I think it's good practice what you're bringing up, that you should have that point built into you and practice it to say, this is a time to step back, take a look at the data we have, be objective, and then go back into it again.
Yeah, I think a lot of this really comes back to the idea of Occam's razor, which we know is kind of this, it's not a hard tenet of medicine, but we talk about it all the time. And the idea is that there should be a unifying diagnosis. There should be one diagnosis that brings everything together. But that's not actually what Occam's razor says. Occam left open the possibility for multiple things to be going on and said we should look for a single diagnosis when we can, when it fits. But sometimes the patient's not going to fit. And so I think Hickham's dictum is probably the better version of Occam's razor, which is that the patient can have as many pathologies as they damn well please. And in the ED, we know this to be true. The patient doesn't just present with sepsis. They present with sepsis, but they were also found down in their apartment where they've been for 3 days and they're hyperthermic. Maybe they have an environmental hyperthermia as well. Oh, and they also have rhabdomyolysis because they've been lying on the ground for the last 3 days. So all of these things we have to understand that they don't have to fit into a perfect puzzle. And so the patient is allowed to have multiple things going on. And once you allow for that, once you allow for multiple diagnoses to be the reason for the presentation, it opens your mind to a world of possibilities that could be going on and can take you down some very different pathways in terms of treatment.
Yeah, that's so well said. And as you're saying that, I'm thinking about how we learned medicine, going from students to residents to physicians who've seen a lot of things. I think that's what's baked in when you're taking a test. It can only be one thing that's going on.
Right.
Like this person's only coming in with one thing because that's how we've been trained. And in many cases, that's what one patient presents with. But as you advance through the specialty and you start to understand and you see many patients, you just always have to leave the possibility that this person is presenting with multiple different things and they can have as many diagnoses as they damn well please.
That's exactly right. Yep.
Let's go back to this idea of the cognitive pause. So you get there, however you got there, you're having cognitive pause. What is your checklist of things that you're going through to ensure every single time you're considering alternative diagnoses?
All right. So number one on my list is acidosis. These patients who are super sick, they're going to be acidotic. We know they're going to be acidotic. Hopefully we get a VBG or possibly an ABG and it gives us the answer. We get the bicarb back, the bicarb is low, whatever gives us the answer of acidosis. And the reason that's important is because our vasopressors, especially the ones that work on beta agonists, especially the ones that work on beta receptors, don't work very well in an acidotic milieu. They just don't like that kind of a situation. And so that might be why you're ratcheting up norepinephrine, but the patient's not actually improving. And the question then is, what do I do? Because I can't really fix acidosis. I think the easy answer is, I'm going to give them bicarb. But we know bicarb doesn't fix acidosis. It just doesn't work that way. I can give all the bicarb in the hospital to a patient with a pH of 6.9. They're still going to be 6.9 at the end of that, right? I mean, bicarb is a little bit more complicated than that. You're going to have to get like a tox person on to really discuss all of this, or like a renal person to really talk about why. But I know it doesn't work. So I can't just fix the acidosis. But what I can do is kind of pivot and say, maybe I should give a different vasoactive substance. So instead of epinephrine or norepinephrine or even phenylephrine, maybe vasopressin will actually be a little bit more useful because it does seem to be a little bit more helpful in those acidotic milieus. Of course, we need to fix the underlying problem. That's what's going to fix the acidosis and then make the patient more responsive. But it is just a reminder of, well, the reason they're not responding is because their pH is still 7.1 or it's 6.9. And that's why they're not getting better with that. You're just gonna have to try something else. And at the same time, really focus in on what the problem is and trying to fix that. Now, there are situations, you could dialyze someone to increase their pH. That does actually work. But getting that done is tricky, especially out of the ED, unless the patient is well known to the nephro service. It's hard to get dialysis done, especially if the patient is hypotensive on a couple of pressors. But it is something that I will think about. So if the patient has a dialysis, they're really acidotic, they're really sick, I've got them on a couple of vasoactives, I'll put the call out. It's a reminder. Put that call out to nephro and say, hey, I've got this patient. I'm in a bad way. I need some help. See if they can help you. I'm not necessarily going to rely on them to help me, but I might as well ask. All they can do is say no.
Yeah, and that's a great point. And I think sometimes people say like, well, what's my consultant going to do? Well, you don't know that until you call your consultant. Right. You're probably right in your gestalt and your assessment, but you got to make the call. You got to make the call because there have been times in the ED where I've called the consultant and they're like, well, this is really acidotic and they're on 4 pressors. So let's get them up to the ICU. We could put a line in and get CRT going for that person. And I've been shocked. But never. This is something I tell the trainees is never assume what your consultant is going to say. Hear what your consultants are going to say.
That's right. And I'll make it easier for them, obviously. Like I'll put the line in, I can do that for you. Let's tee it up. But I don't see this as much in the emergency department, but talking to my critical care colleagues when this happens and they're like, oh yeah, thanks for calling nephro. They actually came and did CVVHD and the patient actually did get better. It took a while, but they did get better. So starting that process, it also makes it easier for your intensivist to recall nephro and say, hey, I know the ED talked to you about this patient. I've got him on 4 pressors. I'm still not making any headway. My last pH is still 705. What do you think now? And sometimes that can kind of set you in the right direction. So We're playing a team sport here, Haney. For you, it is still a team of one. Like you work downstairs and upstairs. So you admit the patient and then you run upstairs and take care of them upstairs. But we have to work with the intensivist. So there are lots of phone calls that we get asked to make and lots of consultants we get asked to call that are irrelevant to the patient's immediate care. But this is one where it can really be helpful. So put in the call, have them know about the patient, know how sick they are, see what they can do.
I want to break in here to tell you about a conference that I'm very proud about, and that is the RESUS conference. This is going to be our 7th year of doing this conference, and this year we're doing it live in Philadelphia, September 29th, September 30th, and October 1st in the Punchline Comedy Club. This is going to be our biggest and best year. We have an incredible faculty, including Anand Swaminathan, who you're hearing from right now, as well as 30 other faculty, and we're adding a little bit more as the days go on. So I want you to go to resusx.com. I want you to check out the schedule, and I want you to register for this conference because we're going to have an amazing time. We're going to be talking resuscitation. We're going to be doing demos. We're going to be doing debates. We're going to have fun giveaways. We're going to have social networking where we go out to bars and eat food together. It is an immersive resuscitation experience. We have a limited number of early bird tickets. I hope by the time you see this, it's not sold out. So go to resusx.com, get registered, and we'll see you in Philadelphia in September. Now back to the podcast. All right, so we got acidosis checked off. What's your next checkbox that you're going down?
All right, so next one is hypothyroidism. And this also reminds me of endocrine stuff in general, but hypothyroid is one of the big ones for me because it's really hard sometimes to know that the patient has hypothyroidism, or they're relatively hypothyroid and now they have some kind of a stressor and now they're super hypothyroid. And we can be tipped to this if we look at their med list and they're like, oh, look, they're on Synthroid. Okay, that's really helpful. But we get patients all the time where we don't know their names. They've never been to our hospital before. They don't have a med list. And so it's hard to know that they're on that. Sometimes we ask the family and they're like, oh yeah, they take all these meds. And then people push hypothyroidism out of their mind because they're like, oh, well, they're on thyroid hormone replacement. And the family says they always take it. So it can't be hypothyroidism. I'm like, well, if they have hypothyroidism, even if they take all their meds, when they're stressed, they're going to need more. They're going to need more of that thyroid hormone because that's what our body does when it gets stressed. It can ramp up production a little bit. The patient can't do that. So we might have to step in there. Now, obviously, if the patient has like a big scar across their thyroid, very helpful. But what I'm looking for the hypothyroidism, and I got this from our friend George Willis, is I'm looking for the pan lows. I'm looking for bradycardia, hypotension, altered mental status, hypothermia, hypoglycemia. Any combination of those things makes me think about hypothyroidism. So we see lots of septic patients who are hypothermic. Hypothermia is something that we know happens in sepsis, but if it's like July and the patient comes in at like 88 degrees, I'm like, well, that's weird. Like, okay, we can treat them for sepsis, but could they also be hypothyroid? Is that part of the issue here? Because that's weird. People shouldn't be 88 degrees in the middle of the summer. So we have to kind of remind ourselves that when you see a low temp, if you see bradycardia and hypotension, that's an uncommon set of vital signs together, right? When I see hypotension and bradycardia, and we'll come back to this in a little bit, I think about beta blockers and calcium channel blocker toxicity and hypothyroidism. So if I see any combination of those lows, I'm thinking about hypothyroidism. And we've talked about this before. I'm pretty aggressive about treating it. If I'm wrong, all I've done is given the patient a single dose of thyroid hormone. Not really that big of a deal. So I'm going to be pretty liberal about giving them thyroid hormone. If I'm 100% convinced the patient's got a scar across their neck, they're supposed to be on thyroid replacement, but they haven't been taking their meds, then I'll give them T3 and T4. If I'm not sure, I'll at least give them the T4. And along with that, I'm giving them steroids. Now, we didn't talk about this, but anytime that I get to that 0.15 mics per kilo of norepinephrine, I'm throwing steroids at the patient too. Again, it used to be a higher number. It used to be when I'm reaching for a second vasopressor, I start the steroids. If I get up to 0.15, I'm throwing steroids at this patient. Hypothyroidism, another reminder, they need steroids too. They probably also have some adrenal insufficiency or some relative adrenal insufficiency. So I'm going to throw steroids, take out both of those endocrine processes at the same time. So if I'm giving thyroid hormone replacement, I'm also giving steroids.
So as you know, we've been doing this a long time. No one reads the textbooks. These patients don't come in. If you do have that patient that doesn't exactly look like the bradycardic or the hypothermic, but that's number 2 on your checkbox list, are you just sending the thyroid panel just because it's like, look, I got to be rigorous here, and this person might not have read the book.
Yeah, absolutely. I'm sending that thyroid hormone level, the TSH. And, we talk about saving some labs or saving some testing. This isn't the place to save stuff, right? This patient is sick and dying in front of you. Sending a TSH is not a big deal. But I work in a place where TSH turnaround is 36 hours. If I send a TSH right now, I ain't getting it back until tomorrow night. So I can't wait for that level. There are places where you can. TSH is a weird kind of test because you can have a normal TSH level and still be hypothyroid. But in general, if I have a low suspicion or I'm just like, maybe it's hypothyroidism and I can get a stat TSH and the TSH is negative or it's normal, then I probably won't give the thyroid hormone. And I think that's totally fine. I'm just operating from a place where it's just not going to happen. I'm not going to get that number back. And if you don't treat that hypothyroidism, the patient's never getting better, right? Mixed edema coma or severe hypothyroidism, whatever you want to call it, has a very high mortality rate. So we have to be aggressive. We can't wait 2 days to start treating that. If I give the dose, that does a lot of things. One, if I'm right, great. If I'm wrong, no big deal. And it makes somebody else think about it as well. Like, oh, they gave a thyroid hormone to this patient. Like, why did they do that? Is this something we need to chase down? So I think that's really helpful in communicating to the next team about what you did, why you did it, and what they should be thinking about too.
Let's go on the third thing. We've done pH, we've done acidosis, we've done thyroid. What's next in your checkbox
All right,
list?
so I'm going to skip over adrenal because we kind of talked about it already. Adrenal insufficiency is there, right? If you read the textbook, you're looking for hyperkalemia, hyponatremia, hypoglycemia. Haney, how many times have you seen that combination for adrenal? I've seen it one time. One time.
Boom. You've seen it
I've seen
once?
I've seen it once.
That's once more than
me. Let me tell you about the patient. The patient came in and said, I have adrenal insufficiency. Okay.
That's not good. That doesn't count.
And I haven't had my meds for 2 days. Okay. I was like, okay.
It's like they're giving you the diagnosis.
Yeah, it's like, okay, great. I'm going to give you so I've never seen it in a patient where I didn't know that they were adrenally insufficient, right? So it's you can't rely on that. What you're looking for is anytime you're going up on your vasoactives and you're not getting the response you like, throw steroids at them, right? I mean, one of my mentors used to say that every patient deserves a course of steroids before they die. So the sicker the patient is, the more likely they're going to benefit from steroids, the more likely there is some part of the immune system that is overreacting. So even if the patient isn't adrenally insufficient, they're probably going to benefit from steroids. We know in severe pneumonia, there's a clear benefit to steroids, right? That Cape Cod trial. So I'm pretty liberal about giving them a dose of steroids. So we'll take that out. So the next thing on my list is anaphylaxis. Now, I'm not saying that the patient came in with hypotension, tachycardia, hypoxemia, and a cough because of anaphylaxis, although that's possible. What I'm really kind of thinking is, could it have been something I did? So this patient was septic. They did have pneumonia. I treated them for pneumonia, but oh crap, I gave them anaphylaxis by one of the medications I gave them, right? Maybe they had a true penicillin allergy and I gave them Pip-Tazo. Or maybe they took something before they came in, and this is a second problem. So anaphylaxis has to be in there once you start treating them with a bunch of meds. I've had 2 cases where it was clearly something we did that caused the patient's anaphylaxis. So they came in with one thing, and then we gave them anaphylaxis on top of it. And it's because the patient was altered, we didn't know their history, and we gave them a med they were clearly allergic to. We found that out later from the family. So what does this mean in terms of what do I do? Because hypotension alone can be anaphylaxis. We know that. And that's a really hard one to pick up. But most patients with anaphylaxis will have a rash. So if I'm seeing rash on top of all of those other things, then anaphylaxis pops higher on my list. And I'm not talking about like the petechial rash. I'm talking about like hives, right? If that patient has hives and hypotension, that's anaphylaxis. And we should be adding epinephrine. One way around this is to say that, well, every time that I reach for a second pressor, my second pressor is going to be epi. If you always give epi as your second pressor, then you've already taken anaphylaxis out of the picture, right? You don't have to worry about that diagnosis nearly as much. So that is a nice little safeguard. And epi is often my second vasoactive. If the patient isn't acidotic, I might be moving to epi as my second one to get a little bit more contractility. So that kind of takes it out of play. But if epi is not your go-to, then you got to think about it in these circumstances.
I'll tell you a quick little story. We had a patient who was in the ICU who was having some severe right heart failure and had a Swan-Ganz catheter in, right? And no one in the ED is going to have Swan-Ganz, so that's not the part of the story. The part of the story is this patient acutely decompensated and really dropped their pressure. I mean, really just acutely decompensated. And as we're going through the checklist of things, and I have a checklist that I always go through for any patient in shock, and that's my cognitive pause, where is it hypovolemic? Is it obstructive? Is it cardiogenic? Or is it distributive? And then I go through each of those branch points. That's how I approach any patient who's decompensating. But in this particular case, anaphylaxis was kind of high on my differential because the person's SVR was so low. They were vasoplegic everywhere. They were warm. And the surgeon, I remember, came to the bedside and said, no, it's more cardiogenic shock. I was like, it's not. I mean, there's this one. And he was like, but it's the only thing it could be. I was like, no, I think it's anaphylaxis. You know, this person had just gotten some medication and it tied in very well. And that's actually what we did. We gave epinephrine IM and the patient immediately responded and got better. And the surgeon still walked away saying, yep, it's the epi was helping the inotropy for the right heart. I was like, all right, whatever. You know, but the point is that it would have been very easy to say this guy has right heart failure. He's sitting here in the ICU, but you just have to be able to step back and say like, okay, we have that diagnosis. We can treat for that diagnosis, but what if it's not that diagnosis? And let's keep things open. And so, you know, not that, you know, this is me interviewing myself, but that's my cognitive pause. In addition to all the great things you're saying, I go through the 4 big boxes of shock and say, could it be this? Could it be this?
Right.
Can't determine. Let's get ultrasound in that case.
Yeah. No, I 100% agree. Like, I'm not going to have an SVR, but I can actually touch the patient's hands and see if they're warm.
What? You examine the patient.
Yeah, examine the patient. I mean, listen, if I've got a patient on norepi and vasopressin and their extremities are still really, really warm, I got to think about, could this patient be abnormally vasodilated, even with the norepi and with that vasopressin? And that's probably going to prompt me to consider giving epi. And like I said, I've caused anaphylaxis twice in patients who were super sick because we just didn't have a med list. We didn't know what their allergies were. So you got to consider it, right? We see lots of, for lack of a better term, fake allergies. This is a real one, and we can miss it pretty easily. So anaphylaxis is right up there. Got to consider that. The next thing, and I'm not moving through these exactly how I would do it in real life. You're kind of considering all of these at the same time. But if you're this deep into the patient, you probably have some labs back. And one of the ones that I think we sometimes neglect is calcium, right? We get a VBG or an ABG back. And when we get that gas back, what we look at first is the pH. And we're like, oh, crap, it's 705. That's bad. Oh, crap, the lactate is 15. Okay, well, that's bad. We sometimes miss that there's a whole electrolyte panel that can be really helpful to us, especially that ionized calcium. And I've seen this missed many times. I've missed it before where the iCal was like less than 1. And then when you go back and look, you're like, oh, well, you know, calcium's important because calcium is really involved in contractility of the heart. If you have hypocalcemia, you're going to have poor contractility. It's also involved in your peripheral vasculature and being able to clamp down. So if you're hypocalcemic, you're going to be more vasoplegic. So it's just a reminder to me of look at that gas, look at that ionized calcium, and aggressively supplement calcium for this patient, whether that is calcium gluconate, calcium chloride, doesn't really matter. Just get calcium into the patient.
Is there ever a situation where you're like, I don't know, I'm just going to give calcium. Like this person's really circling the drain and let's just give calcium. Not as like the, you know, code epi, you know, code calcium, because we've already covered that before, that there's little evidence to do it in the undifferentiated patient. But if there's uncertainty and your labs aren't back, is there any harm to giving just a calcium?
I don't have a problem
for the peri-arrest patient, not the cardiac arrest
I don't have a problem with giving that empiric calcium. I typically don't do it because by that point, I usually will have an ionized calcium. It's so quick to get a blood gas in my place. I have that number back. Calcium doesn't have a lot of harm to it. I mean, extravasation and those kind of things. But if you have a good line, giving calcium, really not that big a deal. If you give it and you're wrong, I don't think it's a big problem. Probably the one place that I give it empirically is in trauma. And we're not really talking about trauma here, but in trauma, I give it empirically because I know it's going to dive. I know they're going to drop off no matter where they start. So they're more aggressive, but in most places, I'm going to wait for the gas.
And for some of the newer listeners on there, the reason why in trauma is because they're getting blood products. And that's the reason why they're dropping, because of the chelation that happens. So, and it's something, I mean, it's a little off topic, but since we're talking about checklists here, when you have a trauma patient and you're giving them blood, I'm just polling you.
Yeah.
When do you give them calcium empirically? Is it after the
first 2 units in? So, I mean, listen, if the patient comes in and I know that I'm going to be activating massive transfusion, I just go ahead and give them calcium right up front. Because we know they're going to become hypocalcemic with massive transfusion. Not just that chelating, like you pointed out, but also just the disease of critical illness. Critical illness itself causes calcium to drop. We know that. So between those two things, this patient's going to need calcium. So if I right off the bat know, okay, this patient's got a stab wound to the belly, they poured out blood on scene, they're super hypotensive, they've got a positive fast exam, whatever that amalgam of things is, I'm going to be activating massive transfusion. I hit them with calcium right up front. In the patient that's a little bit more cryptic, like, I'm not sure. Maybe this is like 2 units and then I'm done. I'll wait till the 2 units go in. As soon as I am calling for more than 2 units, they get calcium. So I'm going to give probably 3 of gluconate or 1 of calcium chloride at that point. And then I'm going to wait for my blood gases to continue supplementation. But if you fall behind in calcium and trauma, you're never going to catch up. So you got to get ahead of them.
I think that's great. And again, it's like one of those things like we talked about with steroid. Second vasopressor goes up, you're going to be doing steroids. Next unit of blood's going up, then you got to give calcium.
Exactly.
Having these little things when patients are really hitting the fan is so important to have that built in, these reflexes that you have. We never want to be algorithmic with medicine, but with resuscitation, a lot of things are happening, multitasking. If you don't have certain rules for yourself, you're going to forget them.
That's right.
And so it's really important to make this part of your armamentarium.
And actually, trauma is a really good one to think about the next part of that cognitive pause, which is occult bleeding. And we see this all the time, right? We talked about, did this patient had pneumonia, fell in their apartment. They've been down for a couple of days. When they fell, did they like whack their abdomen or chest onto a coffee table? That happens all the time. So occult bleeding is something we have to be thinking about. Or is it a spontaneous bleed? Patients on a DOAC or warfarin, and they got a spontaneous retroperitoneal hemorrhage, or they hemorrhage into their psoas muscle, whatever, right? We have to consider occult bleeding here too. I've also seen plenty of patients who come in with sepsis, but they also have a GI bleed, right? It's a cirrhotic patient who's septic, but they also bled because their body was stressed, and that's what happened. So,
or DIC,
or
right?
DIC.
They're in DIC from the
100%. So we got to consider it. This is a reminder to me that if I haven't done a rush exam, do a rush exam. I probably have at this point. But what I find, Haney, and we've talked about this too, is sometimes you start your ultrasound and you look at the heart and you're like, oh, the heart's really not beating very well. And so then you start treating that. Or you find a pericardial effusion, so you start treating that. Or you find that the patient has a big RV and you start treating them for a PE, and you forget to finish the rest of the exam. So occult bleeding, finish the rest of your exam, do your rush, look for possible bleeding sources, put a finger in the bottom, see if there's melena, see if there's, dark stool. That's all going to push you towards, in addition to everything else I'm doing, this patient also needs to get blood products.
Hickam, sickum,
Yep.
right? Hickam,
They're allowed to have
I can't say that too
that's
fast.
Right.
You they're allowed to have all those things and more. Okay. So we talked about some of the things that can cause anaphylaxis. Are there any other toxicological causes that we should be considering as part of our checklist?
It's a great reminder. So there's a ton of toxicological causes. There's so many out there that we can't possibly mention them all, but it's just a reminder to me to think about, like, could one of the medications they're on be part of the problem? And this could be, this patient took a handful of beta blockers or calcium channel blockers as an overdose. They got sick and then they got septic. Or maybe it is that they took their regular dose, but they were already sick and septic and their kidneys were failing. And now they're holding on to their beta blocker. They've got Brash syndrome, right? They've got some kind of AV nodal blocker that's being retained by the kidneys, and they're hyperkalemic, and all of that is putting them into this death spiral. So just got to think about it. Could beta blocker or calcium channel blocker be a problem? That sends us down a specific antidote pathway to hyperinsulinemia, euglycemia therapy. Those patients aren't going to get better with your standard pressure. I mean, sometimes they get a little better, but they don't tend to do really well until you actually get an antidote in them. So it's just a reminder to think about all of those things, especially if you have that pair of hypotension and bradycardia, beta blocker and calcium channel blocker, clonidine. They have to be really top of your list.
And to that specific point, I think that's the case where it's a little harder to empirically treat those patients. Because, I mean, I don't know about you, but I do know you. And I know you're not going to give high-dose insulin therapy
correct.
just because it's like, well, it could be.
Yes.
But you're right in the sense that consider it and then do everything that you can to get that information, whether it's having the medical student call the pharmacy to see if they have a prescription that's out there, or getting family to go through all the pill balls at home. But you have to think it, you have to consider it, and then just try to get the information.
Right.
But unlike the other ones we talked about, this is not going to be one of those empiric type things that you do.
I agree. I'm not throwing 1 unit per kilo of insulin on all of my septic patients. That seems like a good way to run into a lot of trouble.
Yeah, for sure.
And then Haley, the last thing on my list, we kind of mentioned it before, but it is the rush exam. And again, we've probably already done pieces of it, but it just reminds me, did you do the whole thing? Did you look for that bleeding in the belly? Did you look for a AAA, which seems silly? Like, are you telling me that the patient's septic and they have a ruptured AAA? No, I've never heard of that case. But what if the patient already has a AAA? They got sick and they fell, right? I mean, like trauma to the belly, if the patient has a big AAA, that can cause rupture. So it's just something to think about. Could this be something that's a clot? That's the issue, right? I mean, we know patients with PE can have fevers, hypotension, tachycardia, hypoxemia. They can have infiltrates on their chest x-ray. So they can, for all the world, look like a pneumonia. But then if you look at the leg and you're like, oh crap, I found a DVT, does that send me back and say, okay, let me look at the heart again. Is there a right heart strain? I'm in a different direction now. I'm thinking about a very different process. So I'm looking for all of those things. I'm checking the tank. I'm checking the pump. I'm checking the pipes. Did I put a central line in and drop a pneumo? I mean, Haney, I wouldn't do that, but there are people that do that, right? So come on, look for it, right? Look for, did I drop a lung? Is there another pathology that's here? All of those things can really be helpful. So I put ultrasound at the bottom here just to remind me, did you finish your exam?
And tell me, when do you do that? I mean, when and what sequence of things? Is it when the second vasopressor goes on? You're like, we got to get a probe on the heart. Is there a specific sequence to it?
As soon as the patient hits the door with undifferentiated hypotension, they're getting a rush exam.
Sure.
Right. So the way that I look at this is the only way that I can figure out what's going on is with the information that I can get from a rush, and I can do that in a couple of minutes. So that's happening right up front. But again, sometimes we find something and then we forget to do the rest of the exam. And so this is a reminder to go back to it. Now, if I did a full exam and I'm treating the patient, when I'm hanging the second pressor, when I'm giving steroids, as I'm thinking about those alternate causes, I say, you know what, let's redo that rush exam. Let's do a second one. What does the heart look like now? Right? If right up front, the heart looked like it was slamming away. And I was like, okay, well, I'm not really worried about the heart. Now I've got a couple of vasopressors on. They're a little bit more peripherally squeezed down. And I look at the heart again. And I'm like, ooh, that heart doesn't look good at all. Right? What changed? Well, before the heart was slamming against a completely open vasculature system. Now I clamp that vasculature down and the heart's like, nah, I can't do that anymore. Right? So the heart was beating downhill when the patient came in. Now it's beating uphill. And that's going to be a reminder again. It's like, oh, well, maybe you need to give an inotrope. So whether that be epi or adding dobutamine at that point, it reminds me to do that. So even if I did the entire rush exam up front, I'm going to do it again at this point.
And that's one thing I find for trainees hard, because it's like, we already did that. It's like, oh, you haven't seen enough patients to know that things change. Things change all the time, minute by minute.
And
it's a really
it's
good
basically
lesson.
free, right, Haney? I'm not talking about like I CT'd this person and now it's an hour later, they're not getting better. Let's CT them again, right? Like that's not what I'm saying. I'm saying let's do a rush exam again, right? That's basically a free test. It's like getting another EKG. Why wouldn't you get another EKG in a chest pain patient? It's basically free. It's painless. Yes, it means that I have to go to the bedside and spend a couple of minutes there, but that's a really small investment of time when we think about all the other things that we do.
But to quote you right now, it's only a couple of minutes. And take it from both of us who have seen enough patients, you will see that patient that completely blows your mind. And you're like, that's not how it looked. And it'll change management. And once you see that, it'll change your practice. So rather than waiting for that patient, just take our advice. It'll happen.
Yeah, absolutely. And then, Haney, there's some other things to kind of think about that I'm kind of adding into the list. So one of the things that we've talked about in the past is the LV outflow tract obstruction. That can definitely cause this type of refractory hypotension. So I'm not that good with cardiac ultrasound. I'm working on it. I'm working to get there, but I'll at least think about it. Like if I've gone through this whole list, I'm like, could this patient also have LVOTO? Let me go back, see if they have an old echo. Let me see if this patient has a history of LV hypertrophy, if they've got something else that would predispose them to this. Or I might just tell the intensivist, hey, listen, I've done all these things. I'm considering LVOTO. Can you come down and help me with that echo? Right? Can we call cardiology and get them to the bedside to help me out? I'm happy calling a friend. I'm happy saying I can't do this, but I'm thinking about it. Let me get a little bit of help. So LVOTO, I'm not 100% comfortable making that diagnosis or ruling it out, more importantly, but I will ask for help in that.
And just make that consideration. A diagnosis that's not considered as a diagnosis, never made, as they say. So I love that. Keep that in mind. And the things that you can do, do them. The things that you can't do, suggest them. And then as long as you're planting the seed in the next person's head, moving on.
Absolutely.
So we went through a lot of stuff, and this was amazing. Let me just kind of take it from the top. We have that patient who is not responding well. We think it's a classic case of sepsis, and it's not necessarily a number on the vasopressor, but it's just something is coming back is not right. We're considering alternative causes. As you're hanging up that second vasopressor, you're thinking about things like pH. You're thinking about things, well, specifically acidosis. You're thinking of things like adrenal insufficiency, like hypothyroidism, like hypocalcemia, like occult bleeding. You're definitely putting the probe and doing the rush exam a second time to make sure that that heart didn't sustain any injury from your resuscitation, or did something develop in the interim, or frankly, did you just miss it the first time around and then you're catching it? Is that pretty much a summary? And then the LVOT. Anything else that you can consider?
No, I think that's great. And I think if you keep in your head that Hickham's dictum, that the patient can have multiple diagnoses, they can have as many as they damn well please, it's a good reminder to say, okay, I feel like this is what was going on, but let me just take a step back. Let me think about this case a little bit more deeply. This is really hard in emergency medicine. We really like to shoot from the hip, stick with that system one thinking, but we just have to take a step back sometimes when things aren't going the way that we expect them to just reassess, take all that information in. And by that point, you probably do have a lot more information to work from.
Beautifully stated. And on that note, we're going to end the podcast here. Swami, thank you for being here again. We come back next time and talk about a different case.
Oh, hell yeah. I can't wait.